Any other questions there? We'll have time at the end too, I think. Okay, so just a couple of slides looking at, again, sort of where are we going with prostate cancer. I think chemotherapy is certainly moving around. We're kind of looking at moving it earlier. But what about all of these other treatments? The treatments that were approved in castrate-resistant disease, perhaps if those are given earlier, we may see similar outcomes, and we just don't know that yet. But certainly the present and kind of planned portfolio of trials for newly metastatic prostate cancer are testing all of those questions. So they're looking at these treatments that have been shown to prolong survival in men with castrate-resistant disease, and we're looking at those use of those earlier. This is the schema from one trial. This is the Stampede trial, which I mentioned earlier, which is the UK trial. From this study, we already have had data from the chemo hormonal therapy group, and similar to our charted trial, there was a survival advantage in those patients. But you can see that this trial also has an arm looking at early Zytiga, early abiraterone. And when the trial was designed, they didn't have an enzalutamide arm. But we may get some more information about the earlier use of abiraterone for men with newly diagnosed metastatic disease in what we typically think of as being the hormone naive or hormone sensitive area, and there are many other studies looking at this as well. In addition, investigators are certainly interested in using, kind of what's going to be the right sequence for use of immunotherapy, radiopharmaceuticals, cytotoxics. How should we sequence these treatments? How can we improve the outcomes for men as we now have this sort of embarrassment of riches, so to speak, of multiple treatments that can be worthwhile? And so some of those trials are also looking at kind of using enzalutamide or abiraterone earlier on with GnRH therapy. So enzalutamide, I mentioned, is a multi-level androgen receptor inhibitor. So it's sort of like a super version of bicalutamide. Bicalutamide works by blocking the androgen receptor at 1 level and enzalutamide at 3. So there is a lot of interest in seeing how complete androgen blockade may be improved by use of earlier enzalutamide. Similarly, abiraterone may be beneficial in that setting. There are also some novel androgen synthesis inhibitors. So TAK-700 is similar to Zytiga. It's a CYP17 inhibitor of adrenal testosterone synthesis. That agent was studied in the castrate-resistant setting, did not show improvements in overall survival, but did have some improvements in progression-free survival. So they've moved it into an earlier phase to kind of see how it might work in new metastatic disease. That's a trial that we have open at Loyola and Hines. There were also some trials using this agent as adjuvant therapy with radiotherapy, like instead of the 2 years of androgen deprivation with GnRH therapy, it was with the TAK-700 in addition. And so we'll see if this potential novel agent may come onto the horizon as well. And then those drugs are also all being looked at in non-metastatic castrate-resistant prostate cancer. We have a very small kind of subset of patients who develop castrate-resistant disease before they develop their metastatic disease. And that is a real challenging population because these men have had biochemical relapses. They've been treated with androgen deprivation, stopped responding to androgen deprivation, and the suspicion is that they have just as yet clinically undetectable micrometastatic disease, but it hasn't emerged. And we have no treatment options right now for those men. So we tell them, well, we just are gonna wait until your metastatic disease emerges. Right now, we don't think that that's an unsafe approach, but of course it's distressing to a patient to hear that we have their PSA rising, why can't we intervene? And so there are trials looking at treating these M0 non-metastatic castrate-resistant men. We have a trial looking at a similar agent to Zytiga in that setting. So those patients should also be considered for clinical trials so that we can learn more about how to best treat them. What about the idea of combining these therapies? So enzalutamide is good, abiraterone is good. What about the two together? And so it's conceptually attractive. We would be co-targeting the androgen receptor as well as inhibiting androgen biosynthesis. Maybe that's going to be more effective than either one alone. People are also looking at how we can add these agents to Xofigo because that's a radiopharmaceutical. There are non-competing toxicities with systemic therapy like these oral drugs. Similarly with Provenge, Sipuleucel T as an immunotherapy, how can we kind of leverage the benefits of immunotherapy, but maybe while maintaining people on other systemic treatments in order to maintain their response? One caution here is just that we examine combination regimens a lot. We've looked at combinations with chemotherapy when Taxotere was first approved, and very often we get negative trials there. So, while it's attractive to say, well, if one is good, maybe more is better, it is possibly the case that these are just as good in sequence, and in those cases you're potentially having more toxicity when the drugs are combined. So these really this is really investigational at this point, these combinations, and so we'll have to see where this gets to. I think it's important also, we really can't have a talk about new treatments in prostate cancer without talking about the cost of these drugs. So all of them are very expensive, often very expensive for patients. We know more and more that patients are entering into financial distress at the ends of their life because they're being treated with these high-cost medications. So using a drug that costs a patient $1,000 a month in combination with another drug that costs them $1,000 a month, if it doesn't have really substantial benefits in terms of their disease control, then we may not be doing them any favors. And then in terms of other chemo sequencing, on the slide at the beginning, I kind of showed that we did have a novel chemotherapy drug that was approved in the period between 2010 and 2015. That drug is cabazitaxel or Gevtana. This is also a microtubule synthesis inhibitor, but it overcomes the resistance patterns that we see with Taxotere. So there are studies looking at what would happen with cabazitaxel in the first line, different dosing strategies with cabazitaxel, and there's kind of an interesting study that recently completed looking at use of cabazitaxel or docetaxel, and if patients didn't have a robust PSA response, then they were switched to the other therapy to see if there may be mechanisms of resistance that we want to overcome earlier. So we may know more about these approaches as well, hopefully in the next few years. And then one slide about targeted therapy. Targeted therapy is a growing field of interest in all solid tumors and hematologic malignancies. As we learn more about the actual pathway of cancer development, there's a lot of interest in knowing what would happen if we can inhibit parts of that pathway, of course, and actually, biologically inhibit cancer growth. And there are many targets in the development of prostate cancer, and we're not going to go through all of these. But I think the one that would deserve some attention now is cabozantinib, which some of you may be hearing about. It's sort of starting to be talked about in prostate cancer publications and academic presentations. But cabozantinib is a tyrosine kinase inhibitor. It's an inhibitor of MET and VEGF receptor 2. And it was enrolling, the trial that looked at this is the COMET-1 and COMET-2 trial, had some favorable results in prostate cancer. So I think they're seeking FDA approval right now. So this may be kind of our next agent to come. And we all wait anxiously to hear what the real advantages of that treatment might be. And then a final slide just on immunotherapy. Many of you may be familiar with the use of Provenge. Some of your practices may be administering it. And Provenge is a dendritic cell vaccine in which patients undergo leukapheresis. Their white blood cells are exposed to an antigen of prostate acid phosphatase. It sort of trains the immune system, so to speak, to fight the prostate cancer, and then they get the drug product reinfused. People are looking at other types of vaccines, so Prostavac, GVax, Prostatac. These are all various vaccine mechanisms which may eventually come out in prostate cancer as being beneficial. There are other ways to target the immune system, so specifically immune checkpoint inhibitors. So basically these are drugs which release your body's own system of checks and balances over the immune system with the goal of not releasing it so significantly that we result in autoimmune complications, although those are a risk with these treatments. So you may be familiar with some of these. Ipilimumab is currently approved for use in melanoma. Nivolumab or Opdivo, I would bet that about 85%, if not everyone in this room, has seen commercials for Opdivo because they advertise very heavily. But nivolumab right now is approved for the treatment of metastatic lung cancer and also metastatic renal cell carcinoma in the second line. But there are a number of phase 2 and phase 3 investigations underway for metastatic prostate cancer because these drugs really are exciting and promising. Generally, they're not too toxic, and they may also, again, get to our end goal of helping men live longer with their disease. So again, we may be at the breaking point of a longer Renaissance era or a new Renaissance era where we start to think about novel treatment approaches for prostate cancer and kind of targeting our sequence of therapy based on an individual patient's own phenotype. How are they presenting? What does their disease look like? And we make choices based on that. And so I've just kind of created two schematics here where you could imagine a patient who's showing up with high volume disease or poor risk disease. And in that patient, you may kind of initiate them on their androgen deprivation, but think about using earlier chemotherapy in those patients. We may want to utilize immunotherapy to try and maintain control of their disease while then moving on to additional targeted therapies, et cetera, and then eventual supportive care. Whereas if you have a patient who has low volume, low risk disease, you're going to be thinking about keeping chemotherapy perhaps for later on in the disease course and maybe relying more on androgen therapies, targeted therapies, immunotherapies, things that maybe have a more favorable toxicity profile, knowing that the disease course may be somewhat indolent. And for now, I think, hopefully I've emphasized that chemotherapy really is something that we should be thinking of for patients with high volume metastatic disease. We should be offering it to those patients early and having those conversations. It could be considered potentially for men with high risk disease after radiation therapy, but again, that I think requires a really careful conversation with patients about the pros and cons. I think certainly we have evidence to support the use of abiraterone and enzalutamide, which are both approved for either pre-chemotherapy or post-chemotherapy for men with castrate-resistant disease. Immunotherapy, radiotherapy, we consider these at some point in the treatment trajectory, although as I've kind of laid out here, right now we probably have more questions than answers as far as what is the right sequence of these therapies. And then, of course, combinations are still under investigation, so clinical trials are underway. For the meantime, we will use these drugs sequentially and try and achieve the best survivals that we can for our patients. At the end of the day, our practical treatment decisions, so when I'm sitting down in front of a patient, we make treatment decisions based on that patient's individual preference. We try and have conversations about their overall goals of care, especially in the setting of metastatic prostate cancer. It is an incurable malignancy. Although survivals are long and hopefully getting longer, at the end of the day, a patient has to make some choices about what they may or may not want to undergo with their time. We think about the patient's functional status, their comorbid health conditions, how is their disease progressing, and then, like I said, economic considerations. Ultimately, most patients will be exposed to several, if not all, of these treatments that I've outlined. So even though we're giving chemotherapy earlier, I have patients who then will go on to receive Zytiga or Xtandi at the time of their progression. When they progress to kind of traditional castrate-resistant disease, we are then still using second line of chemotherapy, immunotherapy, radiotherapy, et cetera. So most men will survive long enough that they're exposed to multiple of these agents. And I think ultimately this hopefully also emphasizes the need for all of us, urologists, medical oncologists, radiation oncologists, to continue working together. I think prostate cancer is more and more becoming a disease that requires multidisciplinary treatment and coordination very early in the patient's disease course. And so hopefully we can get our patients the best outcome that way. Thank you. I think we may have a few minutes for any additional questions. Please.
So for and this may get to that slide that you had which showed all the targeted response.
Mm-hmm.
But are any of these trials, are they looking at the genomic estimate, the Polaris scoring, or are they actually figure out exactly what
Yeah, so, right. So it's a very interesting question because in other solid tumors, I think breast cancer is obviously the best example. We use a lot of those biomarker or gene signature scores to really be predictive and prognostic for the patient, so predictive of what treatments they might respond to. And there are trials that are in development for prostate cancer, none that are right now in the phase 3 setting. Polaris hasn't been incorporated into any phase 3 trials that I'm aware of, but I think they are looking in a smaller scale. And then other types of gene signature or measuring a biomarker kind of pre-treatment to see how it might come out. It's a very interesting area and certainly something we're all looking at.
that type of assay is heading down the right path?
I think that we will get to a point where some assay is being used because we all know that PSA is really imperfect, but our treatments are completely based on PSA right now. And so I think we need something. I don't know if that particular test will ultimately be the one, or if there may be something with circulating tumor cells that we could measure or something like that. That's another area that's in development. But yes, I think something will come along that is better than what we have now in terms of biomarker measuring. Yeah. Any other questions? All right, thank you.